So, to continue talking about assessing nearness to birth, things that we need to consider when we're thinking about that are the color of the amniotic fluid. When the woman's bag of water ruptures, typically that fluid is going to be clear to maybe a little tinge of yellow and with a little bit of flecks of vernix in it, and that vernix is white in color. And basically, the vernix is the covering of the fetus's skin to help protect that fetus while it's in utero. The amount can vary from a large gush to maybe just trickling that she feels like her underwear or the pad she is wearing continue to get wet. The odor is very distinct and kind of a musky smell, but that odor shouldn't be anything foul or really odoriferous. It should not be green. If that is the case, then we're going to be looking at probably meconium in the stool, and we'll talk or in the amniotic fluid, and we will talk about that on the next slide. Once that bag of waters again ruptures, again, I need to reiterate the fact that you need to check fetal heart rate. You also need to look at her perineum. You don't have to do a vaginal exam, but you should be looking at her perineum to make sure there is no umbilical cord that maybe has prolapsed out with that rupture. You can determine status of rupture of membrane by using nitrazine paper, and the nitrazine paper initially starts out kind of a golden color, and if it turns dark blue or dark bluish green, then that's a positive result. The downside of the nitrazine is you can have false positive readings if you use surgical lube during any vaginal checks that can alter the color. So the next thing in line is now the amnisure, which is new, but you will be seeing that out in clinical. So we will talk about amnisure in the classroom, but if you'd like to get a little more information on that, you are able to pull up that amnisure video and take a look at that. This information is in box 18-2, page 445. Talking about characteristics of amniotic fluid, the color, as I talked about earlier, should be a yellowish, pale yellow. If it is green colored, that means that it could be meconium stained, which means the baby had a bowel movement in utero. And typically, meconium stained fluid means that there's some type of fetal distress. If it's cloudy or a darker yellow, could indicate some infection, or if it's very foul smelling or odoriferous. Amounts, you do need to be aware of oligohydramnosis, which means scant, and polyhydramnosis, which means large amounts of amniotic fluid. And so those are terms that you should make yourself very familiar with. Vaginal exam, the purpose of the vaginal exam is really to talk about the progression of labor. Is the woman's cervix changing? So when we are doing vaginal exams, we need to document on three different things. We need to talk about the cervical effacement. Effacement is always documented in a percentage. So she's 50% effaced, she's 100% effaced, 75%. So we always talk cervical effacement in percents. We always do an initial vaginal exam with admission, and then other things that we have talked about with vaginal exams, with changes, things like that. With the vaginal exam, the station we need to talk about, so where's she at station-wise, and then the number of centimeters. So those three things you'll be checking. And it can be done to determine fetal presentation. So when you're going in to do your vaginal exam, it's palpating the fetus's head and determining where those fontanelles are located, where the suture lines on the head. Suture lines meaning where the cranial bones come together. The vaginal exams can be done by an RN. LPNs can't do them. An RN, your medical doctor, or a certified midwife. When you are doing vaginal exams, you always want to make sure that you're using sterile technique and that you are using KY lubricant. So those are just a few things to be thinking about with vaginal exams. Other additional data that we need to collect upon admission: signing permits, so permits to treat the patient, permits to have the husband or significant other support person in the delivery room, permits for anesthesia or analgesia. The lab tests that we do on admission include a hemoglobin and hematocrit. Typically what you'll see is they do a complete CBC, but you definitely do need to have a hemoglobin hematocrit. Sometimes you'll see urinalysis done just to check on protein. Always review that blood type and RH. So reviewing those prenatal labs, looking where she was at prior to pregnancy, early in pregnancy, throughout pregnancy. So the blood type and RH is important again for the ROGAM, and if mom is negative, baby's positive RH factors, then mom's going to need a dose of ROGAM. You can also be looking for birth plans. If does she have a birth plan? What does she have in mind? Things like that. And then orient her to the bed, the call light, the room, the bathroom, visiting hours, those such things. With standards of care, these are listed out in your book, but standards of care, as far as nursing goes, a lot of it is, safety. We want to ensure that our patients are safe. So looking at your orders, assessing for appropriate and correctness. When you're administering medications, looking at those expiration dates, using standard precautions, being very empathetic, using good communication when you're communicating to that primary health care provider. So using that SBAR, and then document according to your institutional policy. When we talk about fetal heart rates, we need to talk about variability, accelerations, decelerations, early decelerations. This information is covered in Chapter 17. It's in Table 17-2 and Box 17-2 on page 428. So when you're talking about fetal heart rate and patterns, things that we look at are variability. So you want to get a baseline fetal heart rate, and so you need to look at 10 minutes. So when your mom comes in, that's a really important key to that part, is getting her on the monitor and then monitoring her for 10 minutes prior to calling your physician. You want to get a good baseline fetal heart rate. Obviously, if you have tachycardia or fetal bradycardia, you're not going to wait those 10 minutes. But if you have a normal baseline fetal heart rate, waiting that 10 minutes. Normal is listed out up here, 110 to 160. Variability describes fluctuations in that baseline. So when you're looking at fetal monitoring strip, what you're looking for are is that dark line. Does it go up and down? Is it coming up and down going off the baseline? Variability is present in term infants, and when we think about variability and what that means to the infant, is variability gives us a picture or an idea of what that fetus is, how that fetus is tolerating labor, how that fetus is doing. Is that fetus healthy? Is the fetus intact from head to toes? So looking at variability is very important. We see decreased variability in preterm infants. You will see absent or decreased variability after we give narcotics due to it crossing that placental barrier. And then if you have fetal distress, you might be seeing that as well. So with the accelerations, the great thing about accelerations means that when the baby moves, we have a rise in the baseline or fetal heart rate. And to call it an acceleration, it has to be 15 beats for at least 15 seconds. When we look at accelerations and we see accelerations, that is reassuring. That gives us confidence to know that that fetus is doing well in utero, that we have a well-oxygenated fetus. We have wonderful perfusion to the fetus and placenta. So accelerations are beautiful. We want to see them. They are wonderful. Early decelerations can result from head compression, so we're not terribly alarmed when we see early decelerations. And what I mean by early decelerations is that that fetal heart rate starts to dip down before the contraction starts. So we do kind of keep our eye on them, but we can sort of be rest assured that it's probably from head compression, which head compression meaning the baby's head pushing on the cervix is causing a vagus response. So when we're looking at those types of things, early decelerations are not terribly ominous. Now, when we're talking prolonged decelerations, late decelerations, That's the decelerations that we don't want to see as nurses. With a prolonged deceleration, that's a deceleration that lasts more than 2 minutes but is less than 10 minutes. Because if we go beyond 10 minutes, then we're looking at a change in baseline fetal heart rate. So with a prolonged deceleration, it must go down by 15 beats or more, and it lasts more than 2 minutes but less than 10 minutes. Prolonged decelerations have a multitude of causes, so those are listed on your book. Take a look at those. But we do see prolonged decelerations. Maybe if mom has a vagal response and maybe almost faints but not quite, we can see the baby with mom's heart rate dropping. We can see a deceleration with our baby's heart rate dropping. With variable decelerations are okay unless we're seeing multiple variable decels. With multiple variable decels, it can be an ominous sign. Decelerations that are of variable nature usually start and stopped abruptly, so they're very sharp, almost triangular in shape, where your deceleration sort of is very slow to go to the nadir and then very slow to respond and come back to baseline. So variable decelerations are okay, but we don't want to see a lot of them. Late decelerations, the idea behind late decelerations is that they start at the peak of the contraction. So when your contraction is at its hardest or at the most intensity, then we see that deceleration or the drop in fetal heart rate start. So as your contraction goes up, 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 it's peaking now, then the baby's heart rate's going to go down, 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 down. And late decelerations are very ominous. It's not a good sign to see those. We don't like to see those. But when we do see them, it often means uteroplacental insufficiency. I would star that. I would know that. With late deceleration, then that means that our baby's not getting good perfusion, and therefore, if we're not getting good perfusion, then we're not obviously having good oxygenation. So the good, the bad, and the ugly are coming up. So the good, a stable baseline fetal heart rate, 110 to 160. Positive or present variability, accelerations noted at least 2 in a 20-minute period, and a contraction pattern greater than every 2 minutes with duration less than 90 seconds, and a nice relaxation interval of about a minute between each contraction. Lovely, lovely, good, probably going to be a healthy fetus that we have in utero. The bad and the ugly. This is what I'm talking about, late deceleration. So your contraction, it peaks right about in here. And then as we look at this, we see fetal heart rate starting to go down, and then the nadir of the deceleration is kind of after that contraction ends. So when we see those dips like that, those are decelerations we don't want to see. Fetal tachycardia. So if we have a fetal heart rate greater than 160 lasting longer than 10 minutes, that cannot be good. Sometimes women that have dehydration, women that smoke, women that use a lot of caffeine stimulating drugs, fetal tachycardia will be very common in them. So you do need to ask questions, find out what specifically is going on, and then maybe if they're dehydrated, we're going to need to give an IV fluid bolus. But fetal tachy greater than 10 minutes, not a good thing, especially if you lose variability. Fetal bradycardia, that's going to be under 110. When you see fetal bradycardia, especially when you get into those 70s and 80s, that's when you're really going to want to be nervous and be doing your interventions. So turning mom from side to side, getting her on hands and knees, anything to try to increase that perfusion to the placenta and fetus. Multiple variable decelerations, late decelerations, absent, which means loss of. Absent or decreased variability in a term infant are not going to be really reassuring things, and we might be a little bit nervous. So nursing interventions for non-reassuring fetal heart rates. What are we going to do? We're going to reposition our mama. We're going to turn her from side to side, knees and chest, Trendelenburg. Always initiate oxygen, 8 to 10 liters via simple mask. Increase her non-additive, so normal saline, lactated ringers, plain IV fluids. Increase that rate to 900 ml an hour. If she has Pitocin infusing, stop the Pitocin, and then you need to notify your physician as soon as you possibly can. So things to remember with the late decelerations, it's okay to be early, but don't be late. So this is just a nice little pictorial analysis of that. We'll pick up with slide 23 on the next recording. Thanks so much for your attention.